Hello, everyone, and welcome to the Clinics Review Articles podcast series. I'm Taylor Hayes, the managing editor for Clinics in Geriatric Medicine here at Elsevier. Clinics in Geriatric Medicine is a quarterly publication consisting of review articles focused on a central topic related to geriatrics. Today, we will be discussing the recent February 2023 issue dedicated to the practical aspects of cognitive impairment and the dementias, guest edited by Drs. Philip Geriatric and Farzaneh Sarand. Here now is one of the guest editors, Dr. Geriatric from Northwestern University Feinberg School of Medicine in Chicago, Illinois. Welcome to the podcast, and thank you for joining me today. I'd like to jump right in and talk about this issue on the epidemiology, diagnostics, and psychiatric disorders associated with cognitive impairment and dementia. I have no doubt that this issue will certainly be helpful for geriatricians and other primary healthcare providers who encounter patients in practice and who are in need of cognitive assessment. It's also a topic that millions of Americans are familiar with in older friends and family members. So I'm thrilled to have you on as the first issue in 2023.
Thank you very much. It's a pleasure to join you.
The first question I wanted to ask was why you chose to guest edit this issue of the Clinics.
Geriatricians and other primary healthcare providers are frequently asked to evaluate patients with symptoms or signs of cognitive impairment. Over time, we have seen changes in the approaches to diagnosis, prevention, and treatment. An up-to-date, easy-to-read, and digest text in the field comes as a welcome assist for clinicians and researchers.
And why did you choose to organize the issue the way you did?
The book is divided into 6 sections for easy access of information on the practical aspects of cognitive impairment and dementia for the primary care geriatrician, other primary care clinicians, allied healthcare workers, and researchers. The 6 sections include 1, epidemiology of cognitive impairment and dementia, 2, how to establish a diagnosis, and the proper use of cognitive screening tests and formal neuropsychological tests, 3, neuropathologic disorders underlying cognitive impairment and mechanisms by which cognitive impairment may occur, 4, how vascular risks may play a role in dementia and how prevention and treatment of these factors may prevent cognitively impairing illnesses. Also, how does the brain fight off or naturally become less susceptible to cognitive impairment? That is, how is brain resilience, resistance, and cognitive reserve established? Finally, how might we treat vascular and neurodegenerative disorders of cognitive impairment? The 5th section covers the common neuropsychiatric and behavioral disorders associated with the dementias and how might they be managed. 6th, and finally, the last section of the text covers global approaches or initiatives in the field and harmonization of data. There are also chapters on blood and cerebral spinal fluid markers that are beginning to be incorporated into practice, how brain networks, a relatively new concept, and routine and advanced neuroimaging may help the clinician diagnose and treat a patient, and a case-based approach on how to integrate all of the clinical data and establish a diagnosis.
Articles 1 through 5 provide background about the classification and diagnosis of the dementias. Can you share with us some of the highlights of each article?
In the first article, Sabayan and colleagues introduced the term dementia spectrum disorders, or DSDs, as the group of medical conditions and a wide range of pathophysiological processes that ultimately lead to cognitive decline and disability. It is established that more than 55 million persons worldwide have DSDs, with Alzheimer's disease being the most common one, accounting for 60 to 70% of the cases. It is emphasized that more than 1/2 of these cases actually have an overlap or mixed neuropathologies, such as Alzheimer's disease plus cerebral vascular disease or Alzheimer's disease plus Lewy body disease. Sabayan and colleagues go on to emphasize the importance of prevention of cognitively impairing illnesses, especially through cardiovascular risk factor and lifestyle factor modification, and discuss how race, ethnicity, and sex may influence the unmasking and presenting features of the various cognitively impairing illnesses. How then do we establish a diagnosis with cognitive tests? In the second article, Nienhuis and Reckau discuss the strengths and weaknesses of various cognitive screening tests, how to interpret them, and take into account the influence of age, education, literacy level, and underlying illnesses such as medical or psychiatric disorders when administering these tests. In the chapter that follows, Delbeni and colleagues differentiate between cognitive screening tests and formal neuropsychological tests, how to interpret formal tests, and discuss when should referral for formal neuropsychologic testing take place, and define what is the added value of formal neuropsychological test referral. This brings us to the next step, neuroimaging. In Article 4, Binoctapur and Tarabi discuss the role of neuroimaging at the level of structural, functional, and ligand-based tests. In addition, they introduce the concept of how the brain is organized into networks, such as the fronto-executive network for planning, adaptive thinking, and self-control, the salience network, which helps to select external stimuli deserving of our attention, and the limbic network, which mediates our behavior and emotional responses. Different networks may be involved in specific dementias according to CT and MRI brain structural neuroimaging and fluorodeoxyglucose positron emission tomography, or PET, and amyloid PET, for example. This next leads us to the blood and cerebrospinal fluid biomarkers in the diagnosis of Alzheimer's disease and vascular dementia. In Chapter 5, I discuss the role of these markers in practice. These markers fit in well with the National Institutes of Health new framework for the definition of Alzheimer's disease called ATN, where a biologic construct has been created whereby A refers to amyloid beta in the brain, T for tau deposits in the brain, and N for neurodegeneration. Biomarkers may assist in the diagnosis of the dementias, especially early in the process. Regarding biomarkers for vascular causes of cognitive impairment, they are currently undergoing study and are not yet ready for application in clinical practice. However, within the context of a specific clinical phenotype of an underlying dementia subtype, as Alzheimer's disease progresses in the brain, amyloid beta levels drop and tau measures increase in the cerebral spinal fluid. A useful biomarker in the cerebrospinal fluid and blood is the amyloid beta ratio of 42:40. There are various tau tests as well as PET tests for beta amyloid and tau. Biomarker testing should be done and interpreted with the assistance of persons with special expertise in the field. Biomarkers remain a research tool in asymptomatic patients.
Now I want to pivot to the case studies found in the article, What are the key diagnostic cognitive impairment and dementia subtypes, and how to integrate all of the diagnostic data to establish a diagnosis, by Dr. Sheena Baratono and Dr. Daniel Press. What can you tell us about this article, and what is the importance of including these case studies?
In this article, the authors provided case studies of mild cognitive impairment, amnestic type, Alzheimer's disease, mild cognitive impairment, non-amnestic type, vascular dementia, frontotemporal dementia, primary progressive aphasia, and Lewy body dementia, and walk the readers through the diagnostic and treatment paradigms to establish the diagnosis. This chapter is well worth a read as it is full of insightful information. The next several chapters discuss neuropathological and basic brain mechanisms of the dementias.
And what articles discuss dementia subtypes and vascular and non-vascular mechanisms?
In Article 7, Mehta and Schneider discuss the neuropathology of the dementias, and in Chapter 8, Kara and colleagues discuss vascular and non-vascular mechanisms of cognitive impairment. The reader will learn about major genetic, cellular, molecular, and environmental mechanisms leading to cognitive impairment. So there's a whole array of information about mechanism of each type of dementia and the neuropathologic manifestations.
And what can you tell us about the prevention and vascular risk factors and treatment of the dementias?
The next 3 chapters discuss the role of vascular risks and the prospects for prevention, the treatment of vascular and neurodegenerative forms of cognitive impairment, and how does resilience, brain reserve, and cognitive stimulation influence the risk of cognitive impairment, respectively. In brief, vascular risks are precursors to vascular and non-vascular or neurodegenerative types of dementia, according to Mahanrad and colleagues who wrote the chapter. The SPRINT Mind blood pressure lowering trial has shown that intensive blood pressure lowering to a systolic blood pressure target of less than 120 millimeters of mercury compared to standard systolic blood pressure lowering to 140 millimeters of mercury significantly reduces the outcome of mild cognitive impairment and probable dementia. Furthermore, the FINGER multi-domain intervention trial showed that targeted dietary advice, exercise, and cognitive training plus vascular risk factor monitoring and control compared to counseling on general health favored the multi-domain intervention in relation to the neuropsychological test battery results. These findings have led to the FINGER's worldwide network study to validate the findings in a more diverse population. Furthermore, the Lancet Dementia Commission and the National Academies of Sciences, Engineering, and Medicine are now recommending management of vascular risk factors, especially hypertension, to reduce dementia risk based on these findings. In relation to the treatment of vascular and neurodegenerative forms of cognitive impairment, Burlett and Smith discuss holistic patient care for these patients, advanced care planning, and use of cognitive enhancing medications such as cholinesterase inhibitors and memantine. Finally, Dr. Saran and I discuss how brain reserve, the capacity to sustain activity despite some level of brain injury, resistance, the ability of the brain to avoid age-related neuropathologic changes and maintain preservation of brain integrity and function, despite inherent risks such as advancing age and genetic predisposition, and resilience as the brain's ability to handle concurrent neuropathologic changes, yet maintain preservation of the brain and its function. As for good news, lifestyle interventions such as diet and exercise are being studied and are showing early beneficial effects for preservation of brain structure and function.
And finally, what are the themes of the last 2 articles which conclude this issue? And why did you find it important to include these topics?
The last 2 sections, one by Malik and Biffy, discuss the diagnostic and management strategies for common neurobehavioral and psychiatric disturbances among patients with cognitive impairment. And the one by Lipnicki and colleagues discuss how data from multiple sources can be more efficiently utilized to study dementias globally. Medical management of behavioral and neuropsychiatric symptoms require adequate education of the patient and caregiver, development of a comprehensive dementia care plan, and careful titration of medications. Table 5 in the chapter by Malik and Biffy is an especially valuable and concise review of medications, indications, doses, and risks and benefits of drug classes that may be used to treat behavioral neuropsychiatric symptoms. These medications include such drugs as antihistamines, antipsychotics, benzodiazepines, beta blockers, dopamine receptor agonists, cholinesterase inhibitors, and mood stabilizing agents used to treat patients with cognitive impairment and behavioral and neuropsychiatric disorders. The other chapter on the harmonization of data is important because the latest approach to this massive problems of the dementias and cognitively impairing diseases and brain injuries in older persons is now being studied on a more global level, and thus large data sets are being generated. And it's very important to have an understanding of how to interpret these data sets and how they're put together. This particular issue of clinics in geriatric medicine provides a very easy to use, digestible, and single source reference that will help carry geriatricians and other healthcare workers in the field to better understand how to diagnose, treat, and manage patients who may have cognitively impairing diseases.
Thanks so much for taking the time to speak with me today, and thank you to our listeners for joining us for this edition of the Clinics Review Articles podcast series. We hope this issue and podcast is helpful for the primary care geriatrician, clinicians, allied health workers in the field, and researchers on the practical aspects of cognitive impairment and the dementias. For an exclusive discount on the issue we discussed today, focused on practical aspects of cognitive impairment and the dementias, visit us.elsevierhealth.com/expert. Clinics in Geriatric Medicine is available for individual print subscription with accompanying online access, as well as individual online-only access, and is only available on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 65 other titles spanning all medical disciplines, visit info.theclinics.com. Also, be sure to follow us on Twitter at Clinics Reviews and subscribe to the Clinics Review Article podcast wherever you get your podcasts.